Hello, my name is Elizabeth Sully, and I'm a senior research scientist at the Guttmacher Institute. This presentation covers new work from Guttmacher, modeling the potential impacts of the COVID-19 epidemic on adolescent sexual and reproductive health outcomes in low and middle income countries. Previous public health emergencies have shown that the impact of an epidemic on sexual and reproductive health often goes unrecognized because the effects are often not the direct result of infection, but are instead the indirect consequences of strained healthcare systems, disruptions in care, and redirected resources. Adolescents in particular may be vulnerable as health emergencies exacerbate pre-existing inequities in sexual and reproductive care and outcomes. What we do know from past pandemics is that sexual and reproductive health services can be disrupted, and the scale of these effects are large. For example, in Sierra Leone, one of the countries most affected by Ebola, decreases in maternal and newborn care due to disrupted services, as well as fear of seeking treatment during the 2 years of the outbreak, contributed to an estimated 3,600 maternal and neonatal deaths in the country, a quantity that actually approaches the number of deaths directly caused by Ebola in Sierra Leone. We've never lived through a crisis like COVID before, and in many respects, these findings are a modest warning of what we could end up seeing. There are a range of pandemic-related issues that could lead to detrimental effects on adolescent sexual and reproductive health and rights. First, lockdown measures are disrupting contraceptive supply chains and the ability to travel to health facilities, putting young people at a greater risk of unintended pregnancy and by reducing their access to information and to contraceptive services. Second, school closures are leading to reduced access to sexual and reproductive health supplies and information by adolescents, including critical information often offered within school settings, such as comprehensive sexuality education. Third, the economic crisis has driven increases in gender-based violence, child marriage, and other rights violations that threaten young people's health and well-being. But preventative actions can also be taken to mitigate these harms, and these preventative policy actions will also be covered in this presentation. The data presented come from the Adding It Up model produced by the Guttmacher Institute, which measures the need for, the impact, and the cost of sexual and reproductive health services in low and middle income countries, and in particular, the sexual and reproductive health needs, impacts, and costs among adolescents. Our recent report found that as of 2019, adolescents faced vast unmet needs for sexual and reproductive health services. Among those who want to avoid a pregnancy, adolescent women aged 15 to 19 have a much higher unmet need for modern contraception than do all women of reproductive age. They have an unmet need of 43% compared to only 24% among women 15 to 49 years of age. In addition, among the 12 million adolescents who give birth each year, 5.2 million do not receive the recommended 4 or more antenatal care visits. 3.9 million do not deliver in a health facility where they would be able to access life-saving care. It's in this context of already unequal sexual and reproductive health care that COVID-19 is further impacting adolescents' access to this essential care. To understand the potential impact of COVID-19 on adolescent sexual and reproductive care and outcomes in low and middle income countries, we modeled potential service disruptions across 3 main areas of service provision: modern contraception, pregnancy-related care, and safe abortion care. Within each of these service domains, we focused on the changes in the number of people in need of and not receiving care, and the impact that this would have on unintended pregnancies and on maternal deaths. We still don't know a lot about how COVID is impacting sexual and reproductive health services on the ground, so we use data from other COVID-19 models to lay out likely scenarios of how we think services may change as a result of this pandemic. These types of model-based estimates can play a really important role in these situations, where we can show the relationships between service changes and the outcomes for people to make clear just exactly what is at stake if these services are interrupted. This type of data can be particularly helpful for advocacy and for pushing for preventative efforts aimed at minimizing the impact and mitigating the harm. First, we looked at potential declines in adolescents' modern contraceptive use. We used assumptions on disruptions that we may see from each specific modern contraceptive method, And these are data on annual changes that come from a recent analysis from the United Nations Population Division. While the average annual disruption is 12% across all contraceptive methods, this ranged from a 2% decline assumed for female and male sterilization, to 4 to 5% declines in IUDs and implant use, to a 10% decline in pills and condoms, to a 20% decline for all injectables. We also assumed there was no change in the demand for contraception. However, the pandemic and the associated economic downturn may be increasing adolescents' desires to delay childbearing, which could potentially increase the demand for modern contraception when less is available for adolescents to access. So when we assume even just a modest decline of 12% in adolescents' use of modern contraception over the year, we see that this would result in 2 million additional adolescent women with an unmet need for modern contraception. And this in turn would result in 734,000 additional unintended pregnancies among adolescents in low and middle income countries. We also looked at the impact of reductions in pregnancy-related care services among adolescents. To measure service disruptions, we used data from a medium scenario of service disruption to maternal and newborn health services that was recently published by Robertson et al. In the Lancet Global Health. This results in an average decline of 25% in service coverage across a range of pregnancy-related care interventions. We can think of this service disruption as being driven both by changes in access to some interventions, such as being able to deliver in a health facility, but also changes in the content and the quality of care that people are receiving. So we can think of things like the provision of magnesium sulfate for eclampsia treatment. So if we saw an average of a 25% decline over the year in adolescents' pregnancy-related care, this would result in 134,000 more adolescent women experiencing major obstetric complications, but not receiving care for those complications. This decline across antenatal care, delivery and postnatal care, and post-abortion care would result in 3,400 additional maternal deaths among adolescents in low and middle income countries, showing just how essential this care is among adolescent women. The last key service we examine is safe abortion care. Abortion is a time-sensitive, life-saving, essential health service that should not be denied to those in need. Every year, tens of millions of abortions happen safely, but during the COVID-19 pandemic, we're concerned that many of those may suddenly become unsafe. We know from prior work that inhibiting access to safe abortion doesn't make it go away, it only makes it unsafe. So we look at a scenario where 23% of abortions that are currently performed safely among adolescents would become unsafe. That is, that is abortions that do not use a WHO recommended method appropriate for the pregnancy duration or are not done by a trained provider or both. This includes what are classified as less safe as well as least safe abortions. This estimate of a 23% reduction in safe abortion care was based on a childbirth care coverage scenario reduction, which assumed that there would be about a 23% decline, and this was in the Robertson et al. Work I referenced earlier. And so the idea is here, we're assuming that we might see a similar lack of access to facilities and to providers as women are experiencing during childbirth. So we found that if 23% of adolescent safe abortions globally are comprised, that is, that if 23% of adolescent abortions that are currently safe became unsafe, that this would result in 491,000 additional unsafe abortions among adolescents in low and middle income countries. It's important to note that this analysis only looked at what would happen if there was a reduction in the proportion of abortions that women could obtain safely. This could occur through a few mechanisms. Facilities may be closed, women may be unable to travel for services due to a lockdown, staff or resources may be redirected to COVID-related services, and there may be shortages in misoprostol and mifepristone due to global supply chain disruptions. However, this is just looking at what would happen to changes in safe abortion, which underestimates the impact of COVID overall on abortion. There are many countries where safe abortions are already hard to obtain, and women instead are currently having unsafe abortions. These types of abortions may also be impacted by the pandemic. Global supply chain disruptions in medical abortion pharmaceuticals will also impact the use of medical abortion outside of the health system. And people's ability to pay for abortion services will be impacted by the economic crisis that COVID has precipitated. So what we're estimating here is really just what happens when the direct health system provision of safe abortion care is impacted. The scale of impact of COVID on abortion is likely to be much greater than what we're showing here. In addition, some of the other services discussed earlier will have both upstream and downstream effects on abortion care. If there are reductions in modern contraceptive care, this will result in more unintended pregnancies and an increased demand for abortion services. In turn, the increasing lack of access to safe abortion care will result in more complications and an increasing need for post-abortion care. However, post-abortion care is likely to also be impacted by COVID, resulting in an increasing need and less access for this critical and life-saving treatment. So the pandemic is really forcing us now to work differently, more collaboratively than ever before, and highlighting both weak points and opportunities for ensuring stronger health systems in the future. I'm going to talk about a few of these opportunities and thinking about where we can go from here in protecting the agenda for comprehensive sexual and reproductive health and rights for adolescents. First, policymakers need to prioritize sexual and reproductive health care that meets young people's needs, both during and after the pandemic. This means they must define and promote sexual and reproductive health care, including safe abortion, contraception, and pregnancy-related care, as essential, particularly for adolescents and young people. This would then allow adolescents to travel for services, even in areas under stay-at-home orders and with travel restrictions, without the fear of legal consequences. Second, alongside private sector actors, we need to address supply issues by shoring up supply chains to avoid stockouts, making contraceptives available without a prescription, and facilitating multi-month dispensing of contraceptives. Third, we need to repeal restrictive policies such as parental consent requirements, which pose an undue burden, which is even further exacerbated during the pandemic. Fourth, we need to leverage young people's use of digital platforms to promote telehealth options and to make care available to patients in their own homes. And finally, we need to do all of this while addressing the unique needs of vulnerable and marginalized adolescent populations, such as those who are unhoused, those with disabilities, those who are migrants, refugees, or living in humanitarian settings, and those who identify as LGBTQ+. In order for these actions to be successful, both during the pandemic and beyond, young people must be meaningfully engaged in their design, implementation, monitoring, and evaluation. Also, services must be affordable, non-discriminatory, and medically accurate, and developmentally and culturally appropriate. By prioritizing young people's diverse sexual and reproductive health needs and ensuring that they are at the forefront in identifying effective solutions, policymakers can prevent these harms to young people and to strengthen our collective future. Thank you for your time and would direct you here to additional resources from the Guttmacher Institute that you can access. Thank you.